Hey, everybody. It is Wednesday. You know what that means? It's time for Humpday Happy Hour with Dentists in the Know. This is your backstage pass for current trends, politics, and education in the dental world. It is live, and as always, over a cocktail, so we can shed our miseries of the week and talk about some of our great accomplishments. Usually more miseries, unfortunately. Anyway, you know the routine. I am, as always, with Dr. Jennifer Bell and Dr. Chad Duplantis, who are going to come on here shortly. We are all practicing dentists. We are all educators, and we are all practice owners. And our job is to bring all of you in the know. So welcome, everybody. Cheers. Good to see you, my friends. The band is together again. So anyway, guys, I am really excited tonight. So I'm going to tell you that I've been talking about bringing this guest on for a while because she, as well as her late husband, Bob Gerety, had such a huge impact on my career. And so I'll leave a little bit to the formal introduction, but we have Kay Gerety, who is a certified dental assistant. She's been teaching for more than 40 years, teaching dental assistants and in the classroom on practice management. But really where she found her niche was when she teamed up with Bob to teach the Gerety Orthodontic courses. And she's still the head of education at Gerety Orthodontic Seminars. And I've stayed in touch with her over the years. She's trained many of my assistants. She's been there to help me when I've needed help with my cases. She's just brilliant when it comes to orthodontics and really her practice management skills and really team management skills. So I'm just so excited to have Kay with us tonight. We'll get to her in just a few minutes, but Jennifer, you were saying something about news right before we got on the show, and I don't remember what it was, but maybe you could enlighten everybody on what's going on in the dental world.
Well, maybe I'll take this opportunity to do so. Well, the first thing you must know is that due to popular demand, the Dinks News segment is now its own separate podcast episode. So because so many people have demanded, frankly, it was like 2 or maybe 3 total, which is so many people demanded that the podcast include the news. And in order to keep the podcast content timely, we decided to separate the news as its own quick 7 to 10 minute segment, depending on how long I ramble for that particular episode or how exciting the news is. And so now when you log on, starting on Friday, you'll get the most recent current news episode, and then it will take you right into the interview on Tuesday. So hopefully that will satisfy the 2 to 3 people who are very upset that the news wasn't included. I appreciate you very much. It keeps me gainfully employed in this free job that I do every week. So thank you for the validation and also for basically saying that Chad sucks at the news. All good things in my book. But let's get into a little bit of some science-related news. To be fair, the Congress has been super busy with, well, Biden in particular has been super busy with his student loan relief package that just came out today. So there's not a whole lot going on currently in a public forum for dental-related news. There's certainly a lot happening in committees currently with open comment periods. There's the Medicaid proposals with medically necessary benefits being included. That is an current open comment period. And lots of organizations are currently formulating their comments for that package. So just know that that's in the works, but there's not a lot of public things being discussed. But we know that today Biden has released his current plan for student debt relief. We could really get into the weeds on this particular topic. It's a very interesting move, I think, to relieve student debt. If you happen to be a dentist, you probably will not get to take advantage of that because the salary cap does appear to be about $120,000. So sorry, this is really irrelevant news for you, but maybe your kids might be able to take advantage of it. Moving on, there was an article that came out this week in the Journal of Dentistry about periodontal disease and pregnancy. We've known for quite some time the correlation between periodontal disease and pregnancy concerns and challenges with low birth weight and preterm birth. The article that came out, or the research paper that came out from that, highlighted the fact that the periodontal presentation in the pregnancy population does seem to be a bit higher than we probably had estimated. And that essentially from the paper, the recommendation was that this really should be a part of the prenatal screen, education, and care of pregnancy patients, because so many of them do present with periodontal disease. And I would love to see that happen. I think it would validate what we're offering for care. So many pregnant patients actually avoid the dentist during that time period because they're afraid of radiation or other challenges that may happen to the baby, not really appreciating our role in keeping both mom and baby safe. So I would love to see more, PR on what the relationship is with pregnancy and dentistry and how we can kind of go into that journey together. Would be great. The last thing is actually a little bit on the sad side, which the guys always love when I end the news segment on a terrible note. But we did lose a colleague this week to a very senseless act. And anytime that our colleagues are impacted by dumb stuff, frankly, that happens in the community, and it takes one of our great contributing members of our profession, it makes us question a lot of things about what we're doing, but also it's just so senseless and leaves us with a lot of questions. And so Lily Zhu out of Oakland was murdered this weekend with an attempted robbery. And unfortunately, her business partner was with her, or practicing partner was also with her, and had to witness that crime. And, she ultimately passed at the hospital. It's just heartbreaking to see. There's been an outpouring within our profession on several of the platforms that I participate in, talking about what a great person she was and a great contributor to the profession, was well loved and adored by her community for the services that she was providing. She had lived in the U.S. since 1995 and was just targeted senselessly, I think, in an unfortunate situation. If anyone in our community happens to know her or could help provide us information on how we might be able to support or provide outreach, please, send me a DM or something so that we can certainly love on their community and provide support. I don't know her personally, but her story really touched me this week. So with that, guys, I'm going to turn it back over to you.
Gosh, I hate to hear, I mean, you just hate to hear anything like that. So to JB's point, please, if there is anything that we can do as a group or as part of her fellow dental professional group, just please let us know. And, I think these are the times that we all need to stick together. So,
yeah.
All right.
Sorry, guys. It's a slow week, and but I wanted to give her a platform because she seemed like a really amazing person.
Yeah, absolute shame. So on to more positive things. Yes. I am totally stoked about our guest tonight. Can I say that?
Yeah.
Kay Gerety, I am going to bring her up, and she sent an official bio, but Kay, I brought you on here. I sent her official bio, but I'm not going to read her official bio. Instead, I'm going to kind of tell you my story. So anyone who's heard me lecture has heard me talk about the fact that I moved into a town with one orthodontist for the entire county, one pediatric dentist in the entire county. So I decided, hey, you know what? If I'm going to have a successful practice, I need to learn how to treat kids and learn how to do orthodontics. And so that's exactly what I did. I went off for 4 years with a different orthodontic teaching group. And I learned how to do orthodontics as a general practitioner. Also learned about growth and development, how to treat young kids, how to do interceptive. And after 4 years, I had no frigging clue what I was doing. So I had a lot of different opinions, had a lot of education behind me, but really just had no clue. I said, how can I put this all together? And that's when I found Gerety Orthodontic Seminars. I found Bob Gerety and Kay Gerety. Kay, are you there? I don't think she can hear us. We've lost Kay.
We have Kay. I just think Kay's computer might be muted.
All right. Hey, Chad, will you work on that? I'm going to tell the rest of this story. Actually, I have her text. You guys talk amongst yourselves. I'm going to text Kay. I figured something was up. You guys talk amongst yourselves.
I kind of figured something was.
She's so studious.
So I have not taken Gerety seminars, but I have seen them all over. I know that they've been making great dental professionals that can actually treat orthodontics, and we're really excited to have them on. I believe that
I love that they're supporting GPs and that orthodontic pathway. Because I don't know about you, Chad, but how much ortho did you do in dental school?
You know, not as much as I think that we should have. I think that, you know, we learned basically, well, this is going to sound stupid, but we learned the basics.
Yeah.
And, you know, we learned enough to get by. I mean, we did, you know, a little bit of bracketing on teeth that were in wax. We stuck the wax in warm water. It moved the teeth, and it was kind of like, wow. Beyond that, you know, ortho was so competitive. I never even, you know, put a thought to going into ortho. And unlike Jeff, I'm in a very orthodontist rich environment. So it's been, there's Kay. It's been hard to embrace that. So.
Well, I think it's so important because, you know, not only as clinicians, we might venture to treat ortho like Jeff did, where he was trying to meet a need and serve his community, but also just to be educated, to speak, you know, confidently with your referral sources about what you want and what you need from your patient. Also, from Jeff's perspective, encouraging treatment that opens airways and opens a successful teenager, but also an adult. And we have those conversations over and over with patients, but that comes from a level of understanding both orthodontics and sleep, but then having confidence, knowing how orthodontists move teeth. And that only comes from programs that support GPs understanding orthodontics. And those are not easy programs to find. Wouldn't you agree, Jeff?
No, absolutely. Totally. And I think we have Kay back now. There, are you there now?
I am. I'm
so sorry. Awesome. And you couldn't even hear me bragging on you.
Oh, you missed it.
Oh, the love was just oozing out. Kay, above you is Chad Duplantis, and you met Jennifer already. And welcome to Dinks. It is so great to see you.
I am so excited about doing this. You had mentioned it when we conversed a few months ago. You had talked about it, and I had no idea that it would happen this quickly.
Yeah, well, I didn't know it was going to happen quite this quickly. But you've been in the works. You've been in my mind to do this for so long, because what I was telling everyone out there was just how much of an impact you and Bob had on my career. Really quickly, I was just sharing the story of moving to Conway, moving to a town where there was only one orthodontist and one pediatric dentist in the entire county. And so I had decided to learn ortho, but found a different group first to learn it from. So I took courses with this other group for over 4 years, and found out that after 4 years, I had a lot of different opinions, but could do absolutely nothing. I had no confidence. I didn't know what I was doing. There was no rhyme or reason. And that's when I reached out to say, I need to find a teaching organization that can really bring all this together for me and just have one solid opinion. So this time I really asked around. And that's when I found Big Bob Gerety and Kay Gerety. And they've been, they taught ortho courses for more than 30 years. Kay's been in teaching for 40 years, I believe. Is that right?
Bob and I taught together for 33 years.
Oh, wow.
And then I've been teaching for 10 years on my own.
Wow.
Yeah. So anyway, what I was telling everybody was that once I came to your seminars, that really within less than a year, I had these amazing recipes to treat really 95% of the orthodontic cases that were in front of me. And I had a way to do it really confidently. So I've bragged on you my whole career. There's never a lecture that I do that there's not a picture of you and Bob. I post a picture in almost every lecture I do because, I like to let everyone know that I'm not the inventor of all this knowledge, that I'm just the guy that's putting it together and passing it on. And I just want to say thank you for that. But maybe you could share with us Bob's vision for why GPs needed to understand orthodontics and why GPs should be involved in orthodontics, and then the teaching philosophy and how you guys made it what it became.
So Bob was very profound about, and he was very black and white. I mean, he said what he wanted to say. He was very straightforward. And he said, if orthodontics was taught in dental school as it should be taught in dental school, then he wouldn't have a job, because it should be part of the curriculum in dental school. And there, you learn in your 4 years in dental school a lot, but you perfect it when you get out and start working. That's when you actually learn what you've been taught. And you get out and start working. He said orthodontics could be the exact same way. And Bob was very emphatic about making things simple and predictable. And he said, he would always say, just like you have a procedure for crown and bridge, you have a procedure for orthodontics. Now, does everybody fit the same treatment plan? No, they don't. But if you give yourself 5 or 6 treatment plans, usually 5 or 6 with some modifications here or there, can treat the patients. And we try to emphasize, and we still emphasize really strongly, the cases that you should start with. There are cases that should be treated and can be treated and quite simply be treated. And there's some that you should stay away from in the beginning. Another thing Bob always said is the hard cases will always be there because nobody is running to treat them. And so we try to keep people within parameters for the cases that we tell them they should treat. And we say about 85 to 90% of the cases that walk through your door that are malocclusion that you can treat. And we try to give them criteria for not. And when the reason Bob got into doing orthodontics is, first of all, he lived in Henrietta, Oklahoma, population of 3,000. You couldn't pay an orthodontist to come. The nearest orthodontist was just over an hour in Tulsa. So he started taking a course in St. Louis at the dental school at the time. And this was in the 60s. And the first year was didactic. And the second year, they were supposed to do hands-on clinical. And they did the didactic, and when it came time for them to get their top out and did the clinical, they closed the dental school. And he didn't get to finish any of his practical or clinical work on it. And he started going to hear Walt Grimm, who was one of the very first clinicians that taught straight wire mechanics. he was learning edgewise in St. Louis. So he said it was truly a gift from God that they didn't get to do a lot of that because there's so much wire bending involved in edgewise. And so he started with straight wire and started actually teaching it. He started his studies in 1970. And in 1976, he taught his first course at Baylor University in Dallas. That didn't last long.
I'm sure.
But that's where he got started. And he taught with Bill Wyatt for a good while. So, like I said, he started in 1976 and he taught until 2009. And just as, we have, in the last 10 years, we've done a lot of things. We've added a lot to the program. We've updated it with new cases and current cases. And, techniques have changed. Materials have changed. A lot has changed. But a lot stayed the same, too. I mean, Bob's basic foundation and his methods for doing things are still just as pure as they were when he was teaching them himself. And, I've been really fortunate to I've got 4 really, really good instructors that are all past students of ours. And now that they're teaching the course, they're just doing really good work. You got to see Deb and Damon's work this weekend. And this was the first time I had been in the classroom this past weekend in a year because I retired from going. I probably work a lot harder having to send everything and not be there than if I were there to do it. But I enjoy it.
And by the way, she is retired because I actually tried to bring her to South Carolina to do a program. And I vested interest. I wanted to train all of my assistants in orthodontics so that they would all, be ready to step in at any time, because when the 1 or 2 people that really know orthodontics well in your practice aren't there, and there's a lot of ortho patients, that means the doctor has to work. Kay. We lost sound.
The host has unmuted your mic.
There you go.
Is that better? Okay. Yeah. But again, orthodontics is the most delegable, if that's a good word, procedure that you have in your office. I mean, it just really is when you think about it. There's so much that the staff can do for you, and I try to be really honest with people considering orthodontics. Unless you're willing, and you have to get a grasp and get some confidence first before you can start having your system do it. But once you do, if you're not going to let them help you, then you're not going to be profitable at orthodontics, because it takes so long, so much of your time to do it. If you're going to sit and do all, you're not going to make money.
No way.
You're just not. So, that's another thing to consider. They can't pay you enough. You can't charge enough for orthodontics for it to pay for your time if you're going to do all the procedures yourself.
Yeah. But on the other side of that, Kay, one thing that I have to say is that the orthodontic side, so when I started my practice and I got into ortho and I was seeing all these kids, it's amazing how many people ended up coming to my practice because they heard I was doing orthodontics. And I say this about sleep dentistry as well. The people who come to see me because they hear I do a good job in sleep, or they hear I do a good job in orthodontics, and like, oh, you do general dentistry too? Why, yes, we do.
Exactly.
We might be able to help you out too. It's a hidden annuity.
And, one of the things, too, that I thought of while you were saying that is that, do you ever try to send a patient for endo or something? They're like, can you not just do it? Or you send them for an extraction. They're like, couldn't you just do it for me? I mean, patients are really hesitant once they're in your practice. If you can do it, it is. And I tell people, if you would just do phase 1 intersected mixed dentition, which we happen to treat with a fixed technique. I mean, we actually bracket up the primary teeth and go through an arch wire sequence and just get beautiful developed, laterally developed arches out of it. And do nothing but phase 1 interceptive mixed dentition, you would be doing a huge service for your patients, and you would make money at it at the same time.
Yeah.
You know, we charge half of whatever our comprehensive fee is for phase 1. And then in 2 years, 3 years, 4 years, if we decide we need to do a comprehensive to polish it up, if our comprehensive fee is $6,000, then we just take off whatever we charged for phase 1, and we do 9, 12 months of straight wire and finish them up. So they never pay more than they would have, but it sure makes treatment easier. And, you know, there's been so much literature written and studies done about the sooner we reposition malpositioned teeth, especially like lower incisors, little lower incisors that are turned and crooked, the sooner we can get them in an environment, in the neutral zone, and in a good environment and straight, then the better our chances for retention are. So there's a lot of advantages to the patient for doing it, but it also makes comprehensive a lot easier for you.
Yeah. So it's something else that I want to add about the teaching methodology that you all have advocated over the years is that it has always been non-extraction preferred. So, you know, it has never been about making arches smaller. It's been about making big, beautiful, broad arches that people can not only smile big with, but that they can breathe with as well. And I think Bob was so far ahead of his time, because I'm still getting 4 bicuspid extraction cases walking through my door after it's too late. And I say, well, I can open the spaces back up again, but, you know, are we really going to do that? And so that philosophy of growing kids and really fixing 95% of these cases without any need to remove tooth structure, and not even just extraction, but not being so quick to slenderize teeth and make the arches smaller, which is, you know, that's just the quick and easy route for everybody, it seems like.
That's like Bob always said, what would you do if it was your child? Would you be so quick to take a tooth out? Would you be so quick to get a handpiece and start slenderizing, do an IPR? And no, I mean, you try. And it's like you said, those things can happen at the very last straw. Let's say you've gone through all your wire sequence, you've used expansion, you've used arch development. We do, since I don't know if you're familiar or not with Ray Greenfield. He's an orthodontist that he practiced out of Boston. He was in, I think, Coral Gables, Florida is where he was when we went and took his program. But he says it's 99.95 non-extraction. Now, it's pretty ostracized by the orthodontic community because, you know, there's still an extraction, non-extraction that's going on. But he had the most gorgeous arches I've ever looked at. And he did most of his lower arch development with a lip bumper. Yeah. So we have about, I'm going to say 7 years ago, we jumped all in on the lip bumper. And I've never seen any better developed. Plus uprighting the lower molars. We would just constantly seem to have lower first molars that were too far lingual. And even when Norm Setlin looked at Bob's cases, he said, you need to upright those first molars to where you can see the lingual tissue on them. And it's just been incredible. Plus the airway. I mean, you know, I had listened to Bob for years, but I'd never heard him make this statement, and I'd never understood it if he made it. But Deb does a lot of palatal expansion. I mean, if she's in doubt, and she has got us all focused now to looking at the alveolar bone of the maxilla and then the alveolar bone, and just seeing if you drew a line straight down the buccal surface of the maxilla, would it be inside the lower? She said, if it's less than, then we need to do palatal expansion on it.
You can't hurt anyone with palatal expansion.
You cannot. But one of the things that she told me is, she said, think about this, Kay. If you're thinking about a person who has a steep vault and a really narrow arch, then you have the roof of the mouth is the floor of the nose. So if you've got a steep arch like this, then if you flatten it out, then you've just opened their airway and their nasal breathing completely. They can breathe air. If you leave it like that, they've got no chance. They've got no chance for nasal breathing with a really steep vault. But I had never heard it explained that if you did this and then flattened it out, then you've just made the whole surface, the whole nasal openings where they can actually breathe. So
yeah, and you can get a lot of kids out of tonsillectomy and adenoidectomy just by doing that.
Them nasal breathing, because a lot of times they can't breathe through their nose. But once you get them where they can physically breathe through their nose, then teach them to breathe through their nose. And I have seen, and you know, we have used a lot of MyoBrace. I've got a case from a young lady in South Carolina, one of our students, that she did it on her daughter for 9 months, and this little girl changed like day and night, because now she can breathe through her nose. Yeah. Her mom and dad are both dentists.
I don't know if you ever heard of a guy named Earl Bergeson. Have you ever heard that name? So he was the guy who started a company called Night Guide. They were these preformed aligners for children, so far ahead of his time. I heard him speak, and I used them on a few kids, and we developed some arches like that. What I came to learn after being with you and Bob was that it's definitely more effective when you can use fixed appliances on kids, just because of the compliance. It just takes something out of the patient's hand. But I have to say, you know, and now that Night Guide has actually become a company called Healthy Start, which is like a MyoBrace, and they're all doing the same thing now. But we're kind of going back to the 90s. You know, we're going back to the early 90s and saying, okay, let's quit taking teeth out. Let's develop arches. Let's let kids breathe. Let's let them grow normally. And, you know, then if we need to intervene, we can do it again later.
You know, it truly, and it sounds like such an overstatement, but it's not. It changes lives. I mean, it changes, especially for these kids that have never had nasal breathing. It changes their lives to be able to breathe through their nose.
I just wish we could get the medical community on board to really understand how all of these things. I saw a kid today, and I got on my soapbox again about, you know, here's a kid whose tonsils are almost touching in the back, but they don't touch, so the ENT won't touch them. And they have a constricted palate. I'm trying to do an exam, and my mirror won't defog long enough so I can see any of the teeth, because they're breathing through their mouth 100% of the time. He's undersized for his age. And it's heartbreaking, because you think, how does this kid get to me at 7? And nobody along his medical journey has identified or observed these consistent patterns. And the mom and dad, you know, for the first time I saw in the mom's face the validation of, she goes, we've brought him to the ENT so many times because we know something's wrong, and they won't intervene or help or, you know, do any of those things. And then how orthodontics will ultimately play a role. I look at him and I could already foresee he would be a classic 4 bicuspid case. He doesn't even have permanent teeth yet. And I can see that this would be a case that would show up in your office as a 4 bicuspid. And he's already compromised at 7, and then we worsen him at 13 or 14 by taking those teeth out. I applaud what you're doing.
Well, and I tell you, one of the things that Bob used to always say, because we would have students say, you know, my ENT just won't do it. You know, you have to meet this criteria and have had strep and had this and all of the reasons. And again, Bob would say, you need to find another ENT. There are ENTs out there that will listen. I mean, every ENT should acknowledge the fact if a child can't breathe through their nose, then they're compromised. they are compromised in so many ways. And if a child does not have nasal breathing, that in and of itself should be room for something. We've got to do something for him. We were very fortunate. We were in a little tiny town, but we also were close to Tulsa, and we had an ENT that we worked with our entire career. And when he retired, he called and said, "I'm retiring, but I'm going to tell you who does the same thing I do." And if you send them here and say, and a lot of times you do need an ENT to evaluate. Is it something physical? Is it habitual? You don't know. And he said, but he will do exactly what you need him to do. He's very open-minded. And so even after Dr. Nelson retired, then we just fell right in with this other guy. And he was really good. And he would say, "I'm going to do this, this, and this, but right now I don't think they need this." And we're like, whatever it takes, we can teach him we can put in a plan, we can help him learn to breathe through his nose if he can breathe through his nose. Yeah.
So, Kay, you are from Henrietta. Is that where you all practicing?
That's where we practice, yes, Henrietta, Oklahoma.
Are you all responsible for the breathing of a famous NFL quarterback?
Troy is a really good friend of ours.
Is he?
Yes, he is. He's actually a quick, funny story. He's the same age as Bob's only son and youngest child. And so he moved to Henrietta when they were, I think, juniors maybe. But of course, Grant had been playing football and was very good at football. And Troy there, and he said, "Dad, this guy's he's gonna be the starting quarterback. He's gonna be the starting quarterback." And Bob said, "You work harder. You go out there and you go get it. You go get it. You're not going to give it. You're going to go get it." He said, "I'm telling you, this guy's really good." He said, "I'm doing the best that I can." And Bob was like, "Try harder. You try harder. You're not giving your spot up to somebody." And then Bob found out who he was. He said, "Well,
So for those of you who don't know, we're talking about Troy Aikman. So, Kay, do you happen to know a gentleman by the name of Darren Leslie?
I do know Darren Leslie really well. He was our patient.
Darren and his wife are dear friends of my wife and I. We live very close to one another, and our kids are the same age. So we'll chat about it after the show. But yeah.
Darren is Troy's best friend.
Darren is Troy's best friend, and they have been for years. So it's just, I heard you say Henrietta. I said, we got to know some of the same people. But one of the things that I heard you say, and I just want to reiterate, I think there's a huge disconnect between orthodontics and sleep. And I think that, as a general practitioner, it's so hard to find an orthodontist that understands that connection. And, I just love, it resonates so well, the things that you all are saying, that, the straight wire expansion of the arch, non-extraction of the buys. I see so many cases that I just want to bang my head, and then I see so many people, especially my brother's age, that were placed into a class 2 malocclusion by an orthodontist, and they're having these joint problems, and their lower jaw is just pushed back, and it really just drives me nuts. So I love your philosophy. And I also want to say I have a very dear friend that had a very nice comment today about your program, Dr. Jeff Seibert here in Dallas. And Jeff and I have been friends since middle school, and I know that he thinks the world of you all. So love what you all are doing.
Well,
have been doing.
Well, and that was just one of the things that I spent over a year scanning 26,000 slides and digitizing our program and putting it online, because I wanted, and Bob was still where he could comment and give me advice, and he could walk into the room and say, "That's Chrissy Ingram, that's Gerety Orthodontic, that's Amanda Hendricks." And for the longest time, he could still remember names and treatment and stuff. But I wanted to make sure that I preserved his lifetime of work. So I put it all online. And now we have students in 15 countries that take them. We've got all 5 sessions online. The PowerPoint presentations are identical to what I show online. I've got 100 cases documented. I don't have them published yet. I've got 56 of them published of Bob's cases online. That's just in the library that anybody can access to that's got a membership to it. But, you know, Bob spent a lifetime doing what he did, and he did a great job. He did a great job at it. And I just wasn't about to let it go because I think that it's something that every dentist, Bob said, I don't care if you ever put a bracket on it too. You need to know where the teeth are supposed to be in order to function properly. And in order to stay for retention, they need to be, there's only one spot they need to be, and it can't be a little off here and a little off there. He said, if you're going to refer, then at least you know what to expect from the orthodontist. You can say, you know, they're still half class too. I don't know what you're trying to do, but it's not where the teeth are supposed to be. And he said, you owe it to your patients to know what kind of treatment they're getting, and you owe it to your patients to know what's available to them.
Yeah.
You know,
Kay, I've got to jump in and say, I don't, you know, both you and Bob were always very humble about the work that you were doing. It was never about grandstanding and here's where we are. And it was always about really just amazing care. And I'm going to tell you, you will not find any other clinical group that is willing to put all of their models on display and all of their cases on display. And I promise they all finish the same way. I mean, yeah, like any orthodontic case, this one might have had some difficulties. This had some difficulties, but they all finish the same way. Non-extraction, great finishes that look absolutely beautiful that you guys should always be proud of. And thank God that you have preserved all of that in the archives and have it in your online forum now for your students to continue to see. But I don't know if you realize quite how much impact you've had. So do you remember a fellow by the name of Bole Kujit? Bole, he's from Boston. He is actually a fellow Kois. He went out to Kois with me. And we kind of went through the program together at Kois. We became mentors together, amazing clinician. And we brought up so many of the orthodontic principles from Gerety when we were out at Kois that have actually had applicability in the Kois program to this day. And one of the most important things you said was that you have to understand where teeth go in the face. Well, facially driven treatment is where general dentistry is at right now. And, you know, Bob had a saying, and you said how he knew how to simplify things. That's why he was actually able to teach me, is he said, if it looks good, it's good. If it looks bad, it's bad. And I quote him and use that at every single lecture that I do with his photograph up there saying, this is one of the most important statements that I have heard in my dental career, because it's the truth. I don't care what the CEF says. I don't care that you can do 4 bicuspid extraction and have no spaces and someone with an airway problem and a TMJ problem and the teeth are straight. What does it look like? Are the teeth where they're supposed to be? Do they function properly? There's just so much to the work that Bob and you have done, and so it's just incredible.
And I have even people, Bob has a scholarship at OU that we do every year, and it's presented by the orthodontic department. And when we go over, and we have a COVID sort of messed that up a little bit, but the last time that I was there. Oh my.
You got to have a little rousing here.
Oh my. That made me completely forget what I was saying. They were saying
that's what happens to Sooners.
He truly had a vision. He truly had a vision for ortho and where the teeth. I mean, he could finish a case and fine tune a case, and it was like it had been painted almost. It really was. You were saying, you know, the cases finished the same when I was doing the before and afters to put in the headers for the cases that we have documented online. We'd have the before and the after, the before and the after. So Andy had to mount those for me because I don't know how to do that part of it. I can enter all the pictures of the cases and outline them, but I can't do the headers pictures. And he said, I just have to tell you, these after cases, they all look like the same person.
Yeah. You almost have to see the face to make sure it's a different person.
And when you think about it, they do. A lot of them just, you know, they'll have different shaped teeth. And Bob could tell you probably to this day, he could probably tell you, look and tell you, but he had just an eye for it that Deb has. Deb's got that same eye. Damon has that same eye, but they're about the only.
He's talking about some of the other instructors in the program now. Yeah.
And I mean, they just do. They know, because you can put them up there. And Damon did a collage that he had playing before his class started, and it was his cases and Bob's cases, and you couldn't have told them apart. I mean, he's got some really good cases, and so Deb does too. But there is an art to it. But the most of it is understanding what makes, you know, they were teasing a little bit. As general dentist, Bob would go in almost on every single patient and soften the corners of the upper four incisors. He would just take, if there was a square corner that was, you know, had a point, he would go in and soften those every single time, just ever so slightly. And they're like, oh, but you used a handpiece to straighten those, to level them. He said, I didn't touch the incised ledge. I like for the corners on a female, I like for it to be rounded. I just think it's more feminine. I think it's softer. And so he would just go in and just reshape those corners just ever so slightly. Makes all the difference in the world.
It really does.
He would say, are you afraid to use your handpiece? You've all got one. Are you afraid to use it? I mean, you do it if somebody said, can you round that off? You'd say, sure, I will. Kind of thing. So he had a way, and I think he loved what he did. He loved learning. He just was a one of a kind guy.
Kay, do you think one of the advantages of GPs doing ortho is that the long-term relationship? I mean, they're seeing patients, you know, from early on, and then, you know, in a lot of traditional settings, they're referring the patient on to the orthodontist and then back to the GP again. But then the GP's walking them through this long journey, you know, and if we're lucky, we get to participate in it for 15, 20, 30 years, whatever that happens to be. And it gives GPs perhaps a unique perspective on what the long-term benefit, consequence, retention of orthodontics really looks like. So, do you think that's an advantage for GPs in considering doing orthodontics, that they kind of, they see the long-range vision, I think, maybe a little bit clearer.
They do, and they see the reality of, as we age, the things that happen.
Yeah.
But I think it's probably one of the biggest advantages because of the generations that you will see in your practice that you treat. We have treated 3 generations is the most that we have done in our office. But, we see the kids of the patients that we treat, and then we see their kids if you're in practice long enough. So it is. And I just think that the whole thing with keeping patients in your office, when you have patients, that you're keeping patients in your office instead of sending them out to somewhere where they truly would rather not go if you can do it. And I think it's a huge service to your patients. And, you know, you can stay in touch with their hygiene so much better. I mean, there's so much more that we can do for this patient while they're doing orthodontics that the orthodontist don't do.
Yeah. Well, Kay, we're running short on time now. We're almost to 9:30, and you, as the director of Gerety Education, you were gracious enough to offer our group a discount for Gerety Orthodontic Seminars. Now, I'm going to speak personally and tell you that learning orthodontics only makes your general dentistry better, and if you're willing to get your a few assistants trained, it is extremely profitable if, as long as Kay said, you're not sitting there kicking your crown and bridge away so you can sit there and, you know, change arch wires out. You train your auxiliaries to do that properly, which, you know, Kay has a whole team of people there that are just amazing at that. All of my team has been trained by their group, but I will tell you, it makes you a better general dentist to have that orthodontic training. Not to mention how much you can do cosmetically with orthodontics instead of just jumping straight to the veneer or to something else. So I just want to put that plug in and say, I'm going to tell you, there is no better orthodontic seminar out there. I've been through 3 of them myself, and I can tell you by far it was the best of the 3 that I went through. And it's something that you'll never regret. It's quite a value. I think you're offering $500 off if they sign up by the 31st. Is that right? And also you're giving them online content.
Yes, we're giving them complete access to the entire program online. So they'll have that when because sometimes you need to hear something more than once. So they can go on home and use that as a study aid for their, for what they've just done for session 1. They can go home and watch session 1 6 times if they want to.
Well, Chad's a UT guy, so he needs to hear it like 6 or
1,200 times.
I didn't mention this, and I do want to tell you, because I don't know if you have any recent graduates or not, but if you have recent graduates in that are part of your group, we offer them a really special deal. We let them have either the online course, which is $6,000. We let them have it for $5,000, and we let them pay for it in 10 monthly payments of $500.
That's great.
That's great. Grads, and that's and we say recent if it's in the last year-ish, would be a recent grad. And then also, everybody needs to understand that you get to come back the second year. Like, you take all 5 sessions, you do your program, you do all your hands-on, you're all finished up. Then next year you can come back to all 5 programs again. There's no charge for it. It's called monitoring. Now, you don't get to get the materials and do the projects again, but you get to listen to the whole thing. You can bring your cases, you can ask questions. So you get your second year free. And you get 200 hours of continuing education for it. If you do it online, you actually get 125 per year. Because of the way the hours are divided online, there's a lot that's up to you to do online, as far as participating in the program and stuff, and then the research and the things that you have to do, and then the questions that you have to answer, and the evaluations you have to do, which in class we don't do.
Yeah.
So,
what's the website, Kay?
GeretyOrthodonticSeminars.com.
Okay. We will post that for you as well.
That would be great. And I did join your group today. I'm waiting to be approved.
Oh, well, that.
Well, don't ask Chad for that.
That's Jennifer.
No, I did already approve it.
Okay, great.
Yeah.
Well, this was a time.
You're in. You're in.
You're in.
Thank you so much.
It was a tight vote, but I was the deciding
factor. The
factor.
sooner, the better. Oh.
Yeah.
So funny.
All right. Kay, thank you so much for joining us. It was so good to see you.
I'm going to
Kay,
be Saturday.
Do not leave. I want to ask you a question. So hang tight for just a second while we finish the show. All right. All right. Jeff, close us out, man.
All right. Well, one of my favorite people, like I said, those she and Bob have had a real impact on my career. So even though we had a few sound issues, you know what? It was great seeing her, great hearing from her. And it's always nice to relive those Big Bob memories. And he just was an absolute icon in dentistry. And what a pleasure it was to be with Kay tonight. And anyway, I'm happy. So guys, have a great night. It was a good show, and love you guys. And thank you all for watching. Thank you all for being so involved with our Dentists in the Know platform. And we'll see you next week.
See you next week, everybody. Stay classy.
Bye, John Boy.
Stay classy.
Bye, John Boy.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.